Solving crowding cases with aligners are not as easy as you may think. This case presented to be pretty straightforward, but there were a couple things that we needed to take into account before we made any modifications. I'm Dr. Avi Patel, and I've trained over 200 dentists how to start doing aligners, and this case was shared with me. I want to break this case down and share it with you. Check it out. This one's interesting because it's got a situation where you've got crowding and it seems super predictable, but there's actually a couple modifications that I personally would make to this case to make it even more predictable. So anytime I get a case, there is a series of steps that I like to do so that way we can ensure that we are getting predictable results. Before we make any changes, what we want to do is we want to just play this through. Okay, we want to see, is this something that looks realistic? And what do you mean by realistic? So realistic is basically when we play this, does it look like these movements can actually happen if we're putting plastic over these teeth, right? And it seems pretty reasonable. When you look at this, you've got everything slowly progressing through and moving. So in my book, I would say yes, it checks that box. We've covered this first step of reviewing the case and just saying, does this look predictable? Now the next thing that I like doing with these cases is just taking a look at the occlusions. Turn this feature on here, and now we can see this is where the patient started, and the green dots are highlighting where the teeth are occluding. Okay. And whenever I'm looking at my cases, and you should make this a habit of yours as well, you want to make sure that it's actually lining up with how the patient's occlusion actually looks. Because what can happen is if you or your team member takes records incorrectly, that gets translated over to the lab technician. And when they go to mount the case, you will actually have an incorrectly mounted case. And when you have an incorrectly mounted case, you are dead in the water before you've even started, because everything from that point on is going to be okay. So this case is you've got the molar occlusion, you've got the occlusion here in the anterior. This all looks like how it did in the mouth clinically. So we are good in this step. A tip that I always like to share to people is whether it's you or your teammate who's doing this scanning, if you want to get good records and you are having the patient in the chair, do not scan with them sitting down, laying horizontally. What you want to do is when you get the bite record, you want to actually sit the patient up so that way the floor of the mouth is parallel to the floor, right? And then you want to have them bite down, and then that's when you take the bite record. Because when you do that, you're going to get the most accurate representation of where the bite actually is, versus if you have them bite down when they're actually laying back in the chair. So slight nuances like this can actually have a domino effect on the rest of your case. So something to add into your protocol to make sure that these cases are being set up correctly from the get-go. The next thing I like to do is I like to look at all the attachments, okay? So what attachments do we have? Are they doing everything that they need to? Are we missing any? This is where I kind of dive in and take a look and see. For this case, it actually started off like this. So when I see this case, I do not like this attachment. This attachment right here is called, it's an optimized attachment, but it's this half moon attachment. And what it does is it actually puts a corkscrew motion on this tooth, and that is not predictable. Laterals are very difficult to move. And so whenever you see this attachment, you want to swap it for what's called a lateral retention attachment. And this is what a lateral retention attachment looks like. Honestly, the bigger the better, because laterals are very difficult to move with the aligners, very tricky. And so this attachment is really good to help move this guy, grip it, and be able to move it around. So I always make that change. Cool. So what are we missing? So we are actually, in my opinion, we're missing some retention attachments. And what I would like to do is when you place the tray, right? Yes, we're not moving these teeth back here. That's why they're grayed out. However, getting like a horizontal beveled attachment on these premolars would actually serve this case very well, because what that'll do is that will act as anchorage. So that way the actual tray can grip onto these back teeth so that it can then put precise force and movement on the anterior teeth. And so if I had to add an attachment, I would actually add horizontal beveled attachments to these premolars. And what that'll do is that'll help lock in that tray. So that is something that we want to have on our cases. The next thing, looking at this, let's see here. So the next thing I like to look at is what do we got going on with the molars, right? So molar movement in my book is I try to limit it and not even have it happen because it's not that predictable when you're doing these adult cases that you are trying to essentially make predictable. So right now you can see all the molars and the premolars have been locked on this case. So they're not moving one bit. In a case like this, totally fine. Sometimes you do want to get some premolar movement going on, but in this case, we don't have it. So I am totally fine with that. That looks good to me. So what are these blue things here in the front of the case? These are called power ridges. And in this case, you can see we've got two of them. We've got two of them next to each other here. And what they actually do, or what they help do, is they try to do root torque. And so something about power ridges before we mention anything else is you never want to have 3 in a row. The most you ever want to have would be 2 next to each other, because what happens is the tray actually sits, this makes the tray kind of sit off of the teeth. And so there would be a force that's being applied here right to the cervical area of the tooth. And if you've got 3 in a row, that actually doesn't have the tray fitting as well over the teeth. So the limit is always 2. If you have to have 3 in a row, if you have to have 3 in a row, then you can always ask them to stage it. So that's something that you can have them do for you. You just ask them to stage the power ridges. So that way there are no more than 2 in a row. That will really help with your cases in terms of predictability. Let's see. All right, I hope you're finding some value in this video. Now, by the way, if you have a case that you need some help on, you want a second set of eyes, and you want your own custom video feedback just like this, just click the link below and get your free trial for our case review portal. This is something that docs in our Aligner Launchpad get access to, but I want to give it to you for free. Just try it out, drop your cases in. We'll personally review it and give you a detailed video feedback so you know exactly what to do step by step, and then you can go on and make the changes and get one step closer to having more confidence in your cases. Okay, back to the video. Now, what are these blue things here on the back of the teeth? These are called bite ramps. Bite ramps are phenomenal. They are really good for cases where I like to use bite ramps on all my cases except for anterior open bite cases and cases where there is little to no clearance to begin with. And reason being is when you've got bite ramps, what it does is it allows for the mandibular anterior teeth to come into contact. Let's see here, to come into contact with those ramps instead of the actual back of the teeth. And so what that does is clinically, when you've got these mandibular anterior teeth hitting those bite ramps, what that's going to do is that's actually going to open up this bite here. And you're going to open up the bite in a good way because now you won't be getting passive forces which can cause posterior intrusion, essentially pushing those teeth back into the bone, which then results in your case ending in a posterior open bite. So I know these are some big words, but basically to simplify it, when you've got bite ramps on your cases, it is one way to help prevent posterior open bites from happening at the end of the case. If a posterior open bite happens at the end of the case, there's a couple reasons why they happen, and that's the first reason why you need to solve for it. And so one way to prevent them from even happening is to just use these bite ramps in your cases. Now, bite ramps are something that come with the tray, so you do not need to add composite to them. Okay, they are on the tray itself, and it is something that the patient just wears. It also works well if your patient is a clencher or a grinder because it will take a lot of force and pressure off of their masseters there just due to the fact that those posterior teeth aren't clenching and coming down as hard. Going down the list of things to look at, one thing I like to see is how much expansion are we getting? Expansion, making sure that we're not blowing through any buccal plates here. So for this tooth here, we've got some buccal translation, right? So we're expanding everything out, expanding the arch there. And so you want to make sure that you're not going too far because if you do, you can blow through the buccal plate and that is not a fun thing to experience. So for this case, everything is showing less than 2.5 millimeters. 2.5 millimeters is just a rule of thumb. It is not an absolute. The only way to absolutely know if you are expanding if you're going to expand through a buccal plate is to actually look at the area with some type of extra imaging, right? So whether it's a Ceph or if it's CBCT, That's the only way to absolutely know. But in some cases, what I've been taught is rule of thumb is 2.5 millimeters. But you do have to actually take every case into account because every case is going to be a little bit different. So this tooth here, we are actually planning to translate it 3.3 millimeters to the buccal. However, if you look at it, this tooth is set, it's more lingual than the adjacent teeth. Okay. And so the fact that it's moving 3.3 millimeters, to me, I'm thinking, okay, how much, like, where's the bone at relative to the adjacent teeth? Like, how far are we moving these adjacent teeth? So if these teeth were all moving 2.5 or greater, and then you've got something that's at 3.5 or 3.3, that is a cause for concern because that now you are really pushing the limits there. But looking at it, these teeth are only moving about 1.5, 1.8, some even less than 1 millimeter. And so you're fine there, right? Because then you take the difference of that and you're within that range. But where I'm banking on this is I'm banking on there being enough bone here buccally for this tooth to be able to come in nicely. Okay. So that's how you can use a little bit of deductive reasoning to figure out where your limitations are. But again, if you are unsure or you are very worried, definitely get some extra imaging there. That's the best way to know. This case does not have any IPR planned. We are going the route of expansion, which is one way to solve crowding. So there's no IPR to assess here. At the end of cases, I like to look and see how much clearance do we have. So this looks like a decent amount of clearance between the teeth here. And then I'll always check on the table. And this table is showing that we're going to have actually well over 1.5 millimeters of clearance. And that is my benchmark for clearance that I want at the end. Looking at the overjet and the overbite of every case and where are you finishing. And this one is finishing with 3.3 millimeters of overjet and 1.5 of overbite. So collectively, you've got 1.5 millimeters of interincisal clearance. So this case is going to be great. Yeah. So overall, I shared the modifications I would make on this case, adding some attachments that we don't have here just for anchorage. This case, to get this expansion, you're going to want your patients to be using some type of device to help stimulate that osteoclastic, osteoblastic activity, whether it's using the rubber part of the pull tool or a munchie. It's something that is getting those aligners to activate and stimulate that action. If doing aligners is something that you're looking for more confidence in, we actually have a full course. The details for it are in the description below. We also have a website with a bunch of free trainings. It's clearalineradvisor.co. Check those out. Look, my mission is simple. It's to make aligner education accessible to as many dentists as possible. So if you don't want to get into any of the paid stuff and you want more free content, check this video out right here. We go deeper into concepts just like this, and I think you'll find a lot of value from it. I'll see you over there.